Hello everyone, welcome to Medverse, and today we are going to discuss the very important and very essential component of your clinical examinations at you can say clinical postings, and that is we're starting off with the Hutchinson Edison, that is a respiratory system examination, and we are taking away content straight away from standard textbooks, and the most revered textbook, the most famous textbook you get in your medicine postings, which they ask you to read, is basically Hutchinson's, right? So Hutchinson's bedside medicine, clinical medicine, is clinical methods is a very famous textbook. It's not that possible for many of us to read Hutchinson's, okay? But what we can derive from Hutchinson's, I will give you an essence of the respiratory system examination, right? Just be very clear with me that whatever I am telling you, if you don't go and implement in your words, they are of no use. Straight away, they are of no use. So when I finish teaching you, then you go to the words and you take the history of a respiratory system patient. Okay, your seniors will tell you that he is of COPD, is a patient of asthma being admitted, right? The patient of tuberculosis or emphysema or anything they tell you, right? You go and take a history of there, right? And then you try to identify the points which I was teaching. Okay, it should be a retrograde approach. So clinical medicine must be approached in the same way, in a retrograde manner, rather than being reading everything won't help you. Reading Harrison's completely cover to cover without seeing a patient won't help you. You read a small textbook, but you if you apply them to variety of patients, to a wide range of patients, the correct clinical methods, even small lines are of important use, right? With that note, let's start with the respiratory system examination. Here it is written. Okay, four main divisions I will teach you by writing, don't worry. So, four main divisions which you start studying from first year itself is inspection, palpation, percussion, and auscultation. Inspection is basically what you see visually, palpation is what you feel, percussion is basically when you tap. Okay, percussion instruments like drums, right? You tap, produce some sound. So, percussion, where you will check vocal fermitis and other things which you will discuss, and auscultation is basically the jewelry of medicos, jewelry of doctors is basically the stethoscope, what you hear, right? So auscultation is auscultating or hearing with the use of a stethoscope. That thing is clear. Okay, let's start the respiratory system examinations and go sequentially. Okay. A very important line, the first line that is written in your Hutchinson's in this, so there was a call. Okay, we'll start. So first thing which you will, I was telling about the line. That is a golden line in Hutchinson's, that any examination, if you are doing of respiratory system, is incomplete without a proper, you can say, general assessment of your body conditions, right? If you are not examining the head to toe of a patient, if the patient is in respiratory examination, okay, then it is incomplete. Mark my words, it is incomplete, which means that you can't really go and put a stethoscope directly into an asthma patient. You are knowing that it's an asthma patient, but what if he may have any other conditions as well? Okay, so first thing is a general assessment. The general assessment, the very first thing which you are doing in general assessment is the very first thing, and this should not be missed at any cost. And the very first thing is you have to observe the patient. You have to observe the patient. What things you will observe? What things you have to observe? As they enter the room, you have to observe the patient and to ask yourself, is the patient breathless at rest or at movement? Okay, you have to ask yourself. That is, you have to see whether the patient is just coming and being very fatigued, or sitting before you with very fatigued mood. Okay, the person may have walked a bit or climbed the stairs, right? So you have to ask yourself, okay, to see breathlessness, if it is at rest or if it is at movement, okay, on exertion. So you have to observe the patient when you have to observe the patient as they enter the room. If you are taking history, you have to observe the patient. If the patient is undressing for a respiratory system examination, it's fine. You have to observe the patient. Okay. If the patient is being coming and sitting in the stool, you have to observe the patient. Okay. If the patient is climbing to the bed for the chest examination, visual inspection, or something. Okay, you have to observe the patient. Okay, you have to observe the patient. Okay, you have to see breathlessness. You have to see breathlessness. Is the breathlessness at rest or at movement? The breathlessness is at rest or is at movement? Okay. Is any you have to check the vitals, right? You have to check the vitals. What things you'll observe is basically the points to note in general assessment can be remembered by uh, PG breathe. PG breathe. Okay, you have to note these things. The first thing is the physic and the gait, how the patient is working. Physic and the gait. What's the general appearance? Is the patient looking cyanosed? Is the patient's face looking pale? You have to observe that. You have to take the respiratory rate. Okay. So B is for breathing and R is for respiratory rate. Breathlessness. B is for breathlessness. R is for respiratory rate. You have to take the respiratory rate. You have to see if there are any efforts to breathe. Is patient putting efforts for breathing? If the patient is putting efforts, he must be using accessory muscles. So are the accessory muscles used? Are the accessory muscles used? You have to check that. You have to see if the patient is taking any kind of you can say, you have to ask in the history if the patient is taking any kind of tobacco or something, tobacco or smoking, any sort of tobacco or smoking, because the smokers emphysema is very common. Okay, emphysema means it occurs most commonly in smokers only, right? So you don't have any problem in that. Okay, this is done. Then you have to check the hands of the patient. You have to check the hands of the patient. We'll discuss subsequently. You have to overview the hands. Okay, then you have to see the eyes and the face of the patient. Eyes, the face of the patient. You have to see. Okay, these things you have to see, plus some additional things I can add, like you have to see cyanosis. You can get to see in the skin, like tips of the fingers, in the tip of the tongue, you can see cyanosis, right? You have to see the pulses, that gun vitals, right? You have to check the vitals, right? This is systemic examination. Of course we have done the general examination, but I am telling you in the perspective of a respiratory system examination. So these things you do in your general examination only, but these are the things which will point us, which will give us a direction towards respiratory system, so that it are these are the, you can say, warning signs which will prompt us to conduct a proper respiratory system examination, right? So you have to see the pulses, you have to see if is there any swelling in the face, is there any lymph nodes, right? So lymph nodes, you have to check all this in the general examinations. Okay. Okay, now I have some conditions. A patient is of COPD, is of severe COPD, then remember, I yeah, you can add here, the patient will have tight pursed lips in severe COPD. Okay, the person will have tight pursed lips. Okay, pursed lip breathing. like this. Okay, in severe COPD, okay, if you're seeing any collateral veins, okay, any collateral veins in the chest wall, then we'll suspect SVCO. We'll see that, don't worry. Then I told you we have to inspect the hands. Why hands are important? Okay, why hands are important? Because hands will tell you about a person's respiratory conditions in many cases. You can know from the hand itself that person is in this type of conditions. Of course, you have to conduct the proper examination. You have to confirm it. You have to confirm your clinical diagnosis because these are non-specific, right? Not that specific which you are thinking of, right? It's not that specific, but you have to conduct. But how will you get hints? Okay, that are important. So what I'm telling is straight away from your Hutchinson's, so don't worry. If you're not making notes, you can go and read a Hutchinson's. You will have no problem in understanding the respiratory examination after this lecture. Okay, I can guarantee you that. Okay, hands. So what things I will look in the hand which will point me towards some kind of diagnosis? Hands. Look at this. The very first thing which you always see is clubbing. Clubbing. You know clubbing, right? You must have read about your Lovely Bond angle. Okay, in that medicine only Hutchinson textbook it is given. And as Scamroth's window. Scamroth's window, we do like this and go and read. Okay. So clubbing. Clubbing can indicate some lung disorders like some fibrosing diseases of lungs like lung fibrosis. Lung fibrosis. It can indicate bronchogenic carcinoma, bronchogenic carcinoma. Okay, it can indicate your lung fibrosis, bronchogenic carcinoma, lung abscesses. Okay, abscesses of lungs, anything, abscesses, abscesses. Just spelling it, ignore it. All of this or bronchiectasis even. You can just write bronchiectasis also. Bronchiectasis. Many disorders are indicated by clubbing. You are getting pallor in the hands. And whenever there is pallor, we only think of one condition, and that is anemia. Person might have been anemic. Okay, pallor. You can have the palms are very warm. If the palms are very warm, you can think of a situation in which the extremities are warm. In which situation? In septic shock. Okay, but what is the basic thing? If the CO2 is retained, if there is a retained CO2, then the extremities will be warm because there is more cooling in the blood in the extremities, right? So warm hands, warm hands, warm hands. You can say well perfused hands, warm hands, whatever you can tell. This will indicate a sort of CO2 retention. CO2 retention. Okay, warm hands. Now you will see something. This. What is this? This is a tremor. What is the tremor? Is it a tremor? It is a special kind of tremor which I call it asterexis or flapping tremors, like the flapping of a bird. Flapping tremor. This flapping tremor will indicate you again your CO2 retention. And this flapping tremor is also seen if there is a buildup of nitrogenous products inside our body. Okay, so flapping tremors also will indicate you CO2 retention. Warm hands and flapping tremors also. This can also indicate CO2 retention. Okay, this then if there are continuous tremors like post tremors, the person is writing this, there is handwriting problem, there is some sort of tremors like this. Okay, you can ask in the history. You have taken history, right? You have taken medication history. If there is a beta agonist used, then it will show, then it will present with tremors. Okay, which is completely normal. If you miss the drug history, you can diagnose variety of conditions, but you haven't missed the drug history, then you know that it is due to the cough syrup, right? You have prescribed ascoril LS or something, and then the tremors are occurring, right? So normal tremors, not flapping ones, normal tremors may be due to beta agonist use. Beta agonist use, right? Tremors. If there is a bruising or a thin skin, if there is a the skin of the hands is thin, it may be due to lipodystrophy, the destruction of the subcutaneous fat, and this is due to a long-term or chronic steroid abuse. Long-term or chronic steroid abuse. So, if there is a thin skin, then it can indicate steroid abuse. Not abuse, you can say steroid use. You can write chronic steroid use can sometimes lead to thin skin. Okay, if there is a you can know from the pulse findings also. If you see the pulse is bounding, okay, if the pulse is bounding, so this will indicate a hypercapnic situation, a hypercapnia. Pulse I will discuss in the in next sessions, in some day next, because pulse is a completely different part, a completely different piece of medicine which I can say, right? So these things you can know from the hands itself. Isn't it interesting? This many things you can point out, you can suspect, you can say, from the hands itself. Now come to eyes. What can you know from the eyes? Okay, don't expect me to be ophthalmologically correct. I'm just drawing for fun. Okay, no problem. Eyes. What can you know from the eyes? You can see, of course, pallor. Two things I will tell you. Pallor. The second thing is a Horner syndrome. A Horner syndrome. What happens in Horner syndrome? Yes, there is a ptosis, there is a ophthalmoplegia, whatever. I findings are there, right? Ophtha people will talk a lot about that. I am concerned about respiratory system. If there is pallor, it will indicate anemia. If there is Horner syndrome will indicate a very special tumor in the lung. What is the name of the tumor? Can you guess? You have read in pathology. The tumors are called as Pancoast tumors. Pancoast tumors of lung. Pancoast tumors of lung. Okay, very important. So this thing you know from your eye itself. Now let's come to any other thing. We'll you can say examine the lips and the tongue. Lips and the tongue. Don't think of it as the fallopian tube and the uterus, OBGPP. This is your lip and your tongue. Okay. Lips and tongue will indicate cyanosis, some degrees of cyanosis. You can get to know from this. If we are getting if you're getting central cyanosis, then you can suspect it to be a lung disease. If you're getting peripheral cyanosis, then this may be due to inadequate perfusion. Anything inadequate perfusion. Okay. So central cyanosis, lung disease, peripheral cyanosis due to decreased perfusion. You can write. Okay. So these things you knew from your tongue. Okay. Now let's take another color and move to other part. Now we'll see your oral cavity. After you can add here only oral cavity. You will examine the oral cavity. In the oral cavity, if there is a white patches, what is this? Candidiasis. Yes, oral candidiasis. And from oral candidiasis, which is caused by Candida albicans or other species of Candida, you can get to know that patient, you have taken medication history. You can see that patient has been taking steroids, and which condition requires the taking of steroids. Sorry, this steroids you can take corticosteroids, inhaled corticosteroids. Asthma. Okay, so you can get to know retrospectively that the person was a patient of asthma, was previously of asthma. The patient might not tell you, but you can get to know from the this appearance itself, right? So oral cavity, oral candidiasis will indicate you corticosteroid use or immunosuppressant use. corticosteroid use or immunosuppressant use. Okay, these things are clear. Okay, now we will see the venous pulses. What are the venous pulses? Basically, I had written pulses somewhere. Yes. So now we'll discuss about pulses. So venous pulses, you have to see the most prominent one, jugular venous pulse, JVP. So what can you get to know from the JVP? You can get to know if there is a raised JVP, raised JVP. If there is a raised jugular venous pulse, then this indicate right heart failure. That is very right heart failure accompanied by a you can say respiratory distress or a respiratory failure is what we call as cor pulmonale. Cor pulmonale. So raised GBP will indicate if there is a cor pulmonale also, which is common in severe COPD. Common in severe COPD. Okay, this is common. Other thing which I told you in severe COPD, yes, tight pursing of lips. Okay, understood? Okay. Uh, I want to discuss with you a condition that is called as SVCO. What is SVCO? The superior vena cava obstruction. The superior vena cava obstruction will have some findings which you can very well know. And this SVCO patient will, whenever he is coming, will be presenting with a swollen face. A swollen face with engorged neck veins, a swollen face with engorged veins, and you can say some collaterals being formed on the chest wall, collateral chest veins. Okay, collateral chest veins, and usually in the mediastinum there is a malignancy may present with mediastinal malignancy. Okay, so this is a typical presentation of SBCO patient. After this many things is a general assessment. You got a very, you can say, a common idea of what are these conditions and how they are being presented. How we can know from these minute things, you can suspect many things. Right? You might be knowing various things. You might be learning various things. Doesn't matter. In the end, we have to become better clinician, right? Now we'll observe the chest. Okay, now we'll move to the observation of chest. What things you will see. Of course, you have to ask, take consent, ask the patient to undress up to the waist, right? You have to see the rate of respiration, the rhythm of respiration, how the character of chest expansion, the symmetry of chest, the shape of chest, and if there are any previous surgical scars or something. Okay, you have to check this 1, 2, 3, 4, 5, 6 things which I told you. Okay, you can remember like this RR, then there is a C, then SSS. Okay, you can remember RCS, RCS. Let me make it like this and this. Silly mnemonics, just if you want, you can remember. If you are comfortable, then it's well and okay. Just don't miss anything. Okay, just don't miss anything because each and everything will point you, will join the dots towards towards that final diagnosis which you are going to do. Right. R is for rate of respiration. Rate of respiration. R is again rhythm of respiration. Rate of respiration, rhythm of respiration. Uh, you can say chest expansion, chest expansion, and SSS will mean the shape of chest, the shape of chest, the symmetry of chest, shape of chest, symmetry of chest, and if there are any previous surgery or surgical scars, any scars. Just put a question mark here. Okay. So these things, this RCS you have to observe. This RCS you have to observe in each and every patient of coming up with you to your respiratory examination. Coming to you to respiratory examination. Okay. We'll start with let's say uh, okay, the big part, shape of chest. So what how many conditions, let's see, we'll diagnose by just looking at the shape of the chest itself. Okay. Look, if I'm telling you chest, it is the chest as well as the spine. Okay. If I'm telling you chest, it is the chest as well as the spine. Okay. So remember the shape of the chest. First, we can have a overinflated chest. The chest is overinflated. Overinflated. When will the chest get overinflated? If there is some obstruction, the chest will try to overinflate. If there is any restriction, the chest will try to contract, of course. If there is an obstruction, which is the most common obstructive, you can say obstructive disease, respiratory disease which you read, the spectrum, COPD, of course. So overinflation occurs in COPD. Clear? Overinflated chest is done. Chest may have, you can say, a kind of, you can say, you can just see in the middle line. If the chest is like this, protruded, or if the chest is like this, you can say depressed. Okay. So if there is a mediastinal protrusion, which we call as pectus carinatum, and if there is a depression, which we call as pectus excavatum. Okay. So pectus carinatum, pectus excavatum, pectus carinatum, and pectus excavatum. This pectus carinatum, this pectus carinatum is and pectus excavatum. These are congenital diseases. These are congenitally present. I had a photo. Look at this. This is a patient of pectus carinatum. This protruded. If the chest is like depressed, this part is depressed. Okay, then we call it as pectus excavatum. Okay, this type of thing is there. Okay, other thing I told forgot to tell you that if there is a barrel chest, barrel like chest, then most probably the patient is suffering from emphysema. You might be knowing this fact because this is a common MCQ. If there is a flattening of chest, if there is a flattening of chest, then there might be some fibrotic disease. There must be some fibrosis. There must be some fibrosis. You can suspect a fibrosis case. Let's say the person has scars. Okay, the person has scars. Then it is possible that the person might have underwent a surgery like thoracoplasty. Might be thoracoplasty. Might be thoracoplasty. You can get to know these many conditions. Okay. If there is a patient with kyphosis, if there is a patient with kyphosis, scoliosis, you know. So kyphosis will indicate a form of vertebral disease. Okay. You can uh, get to know the vertebral disease. Okay. In case of kyphosis occurs commonly in vertebral diseases. Vertebral disease. You can suspect any vertebral disease or disease of spine. Scoliosis. The scoliosis is a common feature in restrictive lung conditions, right? Restrictive lung diseases, kyphosis and scoliosis. Okay. Other thing which I want to tell you that okay, COPD is one of the most common cases you get. So the examiner tend to ask you more about COPD. Look at this. There is an obstruction due to which the chest is expanding more. The chest is expanding, expanding, expanding. Let's say the chest is you can say lung, not chest. Lung is expanding to this extent so that the diaphragm which was dome shaped earlier. Look at the black. Dome shaped earlier becomes due to expansion becomes flattened sort of. Okay. So what are the findings we saw in case of COPD? The chest wall which was like this became like this. Okay. You can draw here also, right? So as to compare. Became like this. So black one are the physiological one and this all are the pathological one. So what are the findings you can say to your examiner in COPD? COPD patient will have a form of barrel chest. I told you emphysema COPD just a- yes. So I told you emphysema patient or COPD patient will have a overinflated chest or you can say barrel chest. Same thing. Just that COPD is comprising of a spectrum. So emphysema is the type of COPD only. Okay. So don't get confused here. I have written separately, but this emphysema belongs to the COPD spectrum only. Okay. Barrel chest is there in COPD. This I'm talking about COPD. What other thing? Increase anterior posterior diameter. Can you see that? Yes. Increase AP diameter. Can very well observe. Another thing, you will see flattened diaphragm. I told you flattening of diaphragm. And this flattening of diaphragm, how can you see that? Of course, X-ray. Yes. And due to this overinflation, the ribs, when you inhale, there's an inward rib movement. That's paradoxical. Inhaling, you are inhaling more air, but rib must move outwards. As per your physics laws, if it is moving outwards, then it is allowing overinflation. But it is overinflated only. So now, if you are breathing, the ribs will try to move inwards because they have some resistance. So you'll have paradoxical inward rib movement. So these findings are specific for your COPD. Specific for your COPD. So inspection part is almost done. Let's go to the palpation of chest. Okay, what will you palpate in the chest? Palpation. So what things will you try and palpate in the chest? Basically, when I'm talking about palpation, you have to see any type of swelling. You have to see any type of emphysema, surgical emphysema. To check for pain, you have to check for tenderness. If you have to check for the position of trachea, you can say hyperextend the head of the patient and feel if the trachea is in the midline or not. If there is some fibrosis one side, the trachea may be deviated to that side, right? So you have to see that. You have to see okay, symmetry. You have to check it. Okay, I didn't tell you in observation part. Look at this. Symmetry of chest. Symmetry of chest is an important finding because in your pneumothorax or pleural effusion, if there is a big pneumothorax, if there is a big pleural effusion in one lung, then the right side will be burst. Okay, the right side will be burst due to this pneumothorax or pleural effusion in that side. Movement of the chest, you have to see when the patient is breathing. Ask the patient to inhale and exhale, and you have to see the movement of the chest. If the movement of the chest, you have to compare bilaterally, right and left, to see for any sinuses, scars, previous surgeries. I told you. You have to see the apical impulse. If there is a large pneumothorax on right side, it can shift the apical impulse to left side. What's the apical impulse? Apical impulse is basically This is the apex of the heart, and where the apex of the heart is basically, you can say, coinciding, or apex of the heart is there, then here a impulse is felt. This is the apical impulse, most commonly in fifth intercostal space. In small children, since the heart is small, then it is felt in the fourth intercostal space, right? So you can palpate from this, starting from the clavicle, and you can go in intercostal spaces, and you can just feel the fifth intercostal space. You'll see the apical impulse, and where the apical impulse is, then the mid clavicular line. In the mid clavicular line, you can palpate the clavicle and take roughly the midpoint of the clavicle, okay, the mid clavicular, and from the mid clavicular line you draw a line straight downwards, and in the fifth intercostal space you will get your apical impulse. By practice you get to know. So I told you earlier, right, if you are not doing that in your ward or with your patient, it is of no use, okay. It will be of theoretical importance only. There's no this, you can say, practical importance. Apical impulse. So fifth intercostal space or midclavicular line is apical impulse, and if it is shifted towards left, if it is shifted towards more leftwards, then you can assume that there is a pneumothorax. There is some large pneumothorax maybe compressing on the right side, okay, which can shift the apical impulse to the left because the heart is deviated to the left. Okay, you have to turn the patient backwards and then look for symmetry of upper and lower side of the chest, because if there is any fibrosis, then that side will not expand that much, which you're expecting. Okay, okay. Check if the trachea is at center or not. If there is a ask patient to look upwards or hyper extend the neck part, and you look for your trachea. Right? Look at the sternum and spine. Like if you protruded out, I told you pectus carinatum, pectus excavatum. I told you all this, right? Okay. So this part's we completed, and now we are. You can just erase it, and you can write. Then write. What are the causes of chest pain? Okay. So a common complaint is chest pain, and whenever a patient is coming to you with chest pain, what can you suspect? Okay. Okay. So we have. I made a mnemonic like you send the sick infant to MCH building. Sick infant to MCH building. What does it mean? What is the mnemonic all about? So, what can be the causes of chest pain? You have to think about the sick infant. It's nothing to do with sick infant or MCH, just a mnemonic. S. S will stand for a spinal infection. A spinal infection or malignancy can produce chest pain. A spinal infection or malignancy. Then I. I stands for any injury or inflammation. Any injury or inflammation. These are straight away from the tables given with your Hutchinson only. I'm not discussing any other thing. Okay, just Hutchinson. M. There can be a you can say the cancer may affect the ribs, metastasis to ribs. So mets to ribs, metastasis of any cancer to ribs can produce it. C is basically due to coughing, excessive coughing. Cough. There may be fracture also due to coughing, cough fracture. That may be the H. H is basically herpes zoster. Okay, herpes zoster. And of course, you have the cardiac causes as well. Cardiac causes of chest pain. Okay, these things are clear. Now, you will, you can say, assess the trachea and the mediastinum. Okay, if the trachea, how is the trachea? Is the trachea uh, pulled? If the trachea is pushed away, okay, you can see the mediastinum which is pushed away. Trachea, you can see deviations, right? Not pushed away, pulled away. Trachea, you can see deviations, because how will you assess deviations? You will use your fingers on either side of the suprasternal notch. Okay, the sternum, here's the sternum, and the suprasternal notch is there. The fingers will be on either side, and third finger will assess the deviation. Okay, we'll use three fingers, and you can use your fingers, and the third finger will assess the deviation. Okay, so basically, if you're assessing the trachea, we'll use a three finger technique. We tell three finger technique, but use the fingers, other fingers on the side of the. Just you have to, if this is the trachea, this is your neck. You have to put other fingers here. Other finger. You can just take one finger, no problem in that. Other finger, and the third finger, which you are putting centrally, will assess the deviation of trachea. Okay. This is about trachea. Now, what other thing can say? You can assess the mediastinum. And in mediastinum, what things you will assess? Let's say the mediastinum is pushed and pulled, pushed away or pulled towards. Okay. If the mediastinum is pushed away, if the mediastinum is pushed away, what can you suspect? You can suspect your pleural effusion, you can suspect your pneumothorax because the heart, not heart, lungs, because the heart, lungs is expanding. In pleural effusion, there's effusion there. Pneumothorax, okay, the heart, the lungs is expanding, right? So, pleural effusion. Pushed away means you are seeing from the inside the body. You are inside the body and seeing the mediastinum being pushed away, not from your side, not from an observer eye. Pushed away means you are inside your body, you are inside the patient's body and observing the mediastinum in front of you. And the mediastinum is pushed away means it is thing like the chest is expanded chest. Okay, there may be a pleural effusion or a pneumothorax. And pulled towards, if there is a pulling towards, then there can be some sort of fibrosis. If something is retracted, there is a fibrosis. Or what may happen? Or the lung may have collapsed. So lung collapse or fibrosis. Lung collapse or fibrosis. These are the causes of a mediastinal pulling and pushing. I hope you can understand. Okay, this is the now. Now we will assess the chest expansion. Okay, let's write here. Chest expansion. Okay, chest expansion. Okay. You are putting the your fingers on the chest of the patient and the thumbs must meet the midline. Okay, let's say this is the patient. Just a minute. This is the patient's body. You are putting a thumb here, thumb, and the thumb must meet at the midline of the patient's body. This is the midline. Meeting of thumbs. Meeting of both hands, thumbs. Okay. Then the person is asked to take a deep inspiration. Take deep inspiration. If the person is taking deep inspiration, the chest will expand. If the chest will expand, the distance, you can say the distance between the thumb, just that joint, or you can keep at a distance which is less. If, sorry, if it is expanding, if the chest is expanding, then the distance will increase. There's an increase in distance bilaterally. You see bilaterally always, because whenever you're taking BP also you take bilateral, right? Because it can have, you don't know that the patient is having some sort of problem which is bilateral. Okay, patient may have a pathology on one side. So if there is a lung pathology on a particular side, then the chest expansion will be reduced in one side, right? So distance must increase between thumbs. If reduced on one side, if the expansion or the it is reduced on one side, then you can suspect lung pathology of contralateral side or ipsilateral side of that side only. Okay, done. Now we will uh, we have done about the shape of the chest. All of this, just pain and all these things are in the palpation part. Okay, trachea you are palpating, mediastinum, just chest expansion we are seeing. Now comes percussion. You are percussing them. What will happen? The normal note of percussion when you're percussing, okay, the normal note of percussion is a resonant note. Okay, and if there is a dull note, if there is a stony dull note, if there is hyper resonance, or if there is impaired resonance, okay, so we have four abnormal notes. The normal one is resonant note. Let's say we have a we have four cases here. You can get a dull note. If you are getting a dull note, then there must be, if something is present, it will not resonate. Resonance means you are tapping it, right? So you're getting the vibrations reflected, and the vibrations producing some resonance. If there is something blocking that, if there is some sort of pus, if there is a sort of tissue or something is blocking, there's a consolidation. If there's a consolidation, there's a consolidation of your alveolar cells, damaged alveolar cells, right? Any sort of consolidation, you get a dull note. Okay, dull note in consolidations. In consolidation, if you're getting the stony dull note, stony dull note, okay, you can. I will. If you're not understanding the notes, I will take a session on resonance also. Okay, because this is a concept, and I can't teach everything and anything in this particular session. Uh, You can remember for now if you don't know, or you can watch any video for resonance. But these are the findings in particular respiratory conditions, and I'm discussing about respiratory system examination. So I have to discuss all of this, right? If there is a stony dull note, then it is a pleural effusion. A pleural effusion. Pleural effusion. If there is a hyper resonant note, the resonant note is normal. If there is a hyper resonance, if there is a hyper resonance present, okay, hyper resonance will always indicate a pneumothorax. 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 Okay. And the fourth thing is the impaired resonance. Impaired resonance. If the resonance is impaired, of course, there is something which is blocking your resonance. And what can block the resonance? Fibrosis, restriction. Restriction always blocks the freedom. So, impaired, if it is severely impaired, you can say. So, there must be a fibrosis. Must be a fibrosis. Okay. Now, with this, we completed percussion. Let's come to auscultation. For that, you will need a stethoscope. Yes. So, in auscultation, when you put the stethoscopes on the lung fields bilaterally, right, you will get to know some two sounds. Basically, I can't make you hear, but you know that when this is a vesicular sound, if the air is coming, okay, it will come through a hollow spaces, right? So vesicular sound, or if there is a consolidation, the air has to offer some resistance to come. If there is some resistance to come, it is called as a bronchial breath sound. Okay, so if there is a vesicular breath sound, it is normal vesicular sound, breath sound basically. And if there is a bronchial breath sound, this is a vesicular breath sound is completely normal. The bronchial resound will indicate a consolidation again, a sort of consolidation again. Okay. Now, you can get some added sounds as well. Okay. You will get some added sound as well, like you can say wheeze. You can get crackles. You can get pleural rubs. Okay. What are this? So wheeze. We'll see again. Wheeze. Wheeze you will get in asthma, COPD. If you're getting wheeze, you can suspect asthma, COPD. By practice, you just auscultate patients. Okay, get to know the difference between wheeze and crackles and pleural rubs and all. So crackles. What are crackles? Crackles are just like you can say soft bursting of crackers. You can say okay, the small crackers they when they burst softly. Okay, crack, 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 like this type crackles. Okay, wheeze is this type of sound. Okay, and a pleural rub is basically when you rub two papers. Pleural rub. It is occurring in pleurisy. Okay, in a pleural rub because the pleura are basically rubbed against each other due to inflammation of the pleura. Pleural rub can indicate pleurisy. Crackles can indicate any kind of fibrosis. If there is any kind of fibrosis, there may be bubbles which may be bursting or coming. Fibrosis or any kind of edema, pulmonary edema. Pulmonary edema, fibrosis. You can get crackles. Okay. If uh, if the crackles can be divided into two again. This is a big topic, the respiratory medicine, but I'm talking clinical point of view. If the crackles are fine, okay, if there is a fine cracker and they are occurring when the person is inhaling, inspiring, in this terminal stage, the late inspiratory crackles, fine and late inspiratory, this will indicate a definite kind of fibrosis present in the lung. Fibrosis. You may ask the patient to have a chest X-ray also. If there are coarse crackles, then it can indicate a sort of bronchiectasis. Smokers like coarse crackles, bronchiectasis. Okay, these are the things. Now, what is some people don't understand what is a wheeze and what is a stridor? What is a stridor? Stridor is basically occurring in the larger airways, where a wheeze is a smaller airways. Stridor, you can say it is a emergency condition. And it is a stridor. The patient you are in the OPD and the person is in IPD, you can hear this person is in stridor. Okay, so it is emergency condition. It is very loud. It's very loud. It is due to any kind of you can say laryngeal things you can read in ENT also, right? So anything laryngeal edema can produce this kind of stridors, right? So wheeze is always of smaller airways. Okay, so whenever you are just wheeze and stridor, wheeze is a thing of smaller airways. Small airways are involved. Small airways are involved. It is less loud. It's less loud, not urgent. Okay, but here this rider is of larger airways. This is loud and this is an emergency. Okay, so these things you have to understand. Now we have something called as a vocal fremitus, vocal resonance fremitus, where you tell the patient, where you put your hands like this and tell the patient to say 99. Okay, you have to compare 99. You have to compare bilaterally. If there is increase vocal resonance, if there is increased resonance, you have to compare bilaterally, right? The first lung and second lung, 99, 99. You have to compare both sides. Same, no problem. If vocal frematus is absent, what happened? Maybe pleural effusion may be there in that side. If there is an increased vocal resonance, there increase the resonance, then what may happen? There may be a consolidation, maybe a consolidation. So vocal resonance. Ask patient to say 99, because 99 is that kind of syllable that will enable a sort of a resonance in our body. Okay, 99. You can feel when you are saying 99. Okay, and then bilaterally. Compare bilaterally. If there is a increased vocal fremitus, vocal resonance, or a decreased vocal resonance, or absent vocal resonance. Is there a decrease or absent vocal resonance? There may be a pleural effusion there. Pleural effusion. And if there is an increase, then there may be a consolidation. There may be a consolidation. Okay, that these things. So this all will suggest you. These all things which I taught today. This is not complete yet. Not Harrison's, Hutchinson's tell you that these findings will suggest if the condition is obstructive, if the condition is restrictive, it is a pleural pathology, as in pleurisy, get pleural rubbing, you're getting pleural rubbing. If there is an obstructive condition like COPD, the chest is inflated, you can access the diaphragm is flattened, okay, the anterior posterior diameter has increased, maybe obstructive pathology. You are seeing cyanosis, peripheral cyanosis, central cyanosis. You can get to know an obstructive pathology. We're getting the contraction of the chest, the pulling away of the pulling in of the mediastinum. Okay, and you are doing resonance, right? You are seeing a consolidation. Then you are getting increased focal resonance. Okay, you are getting decreased vocal resonance. Then you can chill the, yeah, pleural effusion might have been there. Okay, there may be pleural effusion. You are doing resonance. Resonance can indicate if there is impaired percussion. You can see that there may be a fibrosis. You can tell, you can suggest that the person might have an obstructive pathology, the person might have an restrictive pathology, or the person might have a pleural pathology. But the most important thing, it must be correlated with imaging, and it must be correlated if required with an ABG analysis, arterial blood gas analysis. You have to do correlation with imaging. Okay, you have to do. You have to correlate it with the chest X-ray. You have to correlate it with the spirometry or whatever is needed. You have to correlate it. And with the ABG analysis, you have to see if it is alkalosis or acidosis. It is metabolic. If it is respiratory. You have to correlate it. So that completes our thing. Just an exposure to respiratory system examination. I can tell you everything and anything, which are case specific sometimes, but these are the common things which you have to know in case you are examining the respiratory system. Okay, so if you have any doubts, feel free to reach me in the comment section, or you have my Instagram ID. You can just send a message request with your doubt and your name, which college are you from. I can respond to that query as it is. If you have any doubt in any subject, you can just ask me regarding MBBS, not humanities or arts. Right? Okay, so that's all in today's session. I hope you liked the session. It was very practical, but as I told you, again, I am telling you, if you're not implementing these things, this knowledge which you gained from today's session into your clinics, then this session is nothing good, right? So you have to correlate it. You have to read Hutchinson's again. Okay, because this lectures you have to understand are not the you can say substitute for your standard textbooks, right? So you have to read Hutchinson again and have to implement it on the patient. Okay, and if you want any sort of clarification in anything like which things which I might be like missing out, or I'm not able to discuss in this particular 1 hour session is, let's say, uh who is tried, I discussed, okay, percussion, how to do percussion, okay, what is resonance, what is a dull note, what is a hyper resonant note. I didn't tell. Why? Because I was running out of time, right? I can't tell everything in a respiratory examination system. And let's say about all about COPD. Let's say all about emphysema. Okay, let's say all about your core pulmonale, or all about your Horner syndrome, anything. Let me I can discuss about the accessory muscles and but conditions which will prompt a patient for using the accessory muscles. It will extend, okay. Breathlessness is a topic to discuss, right? I can discuss for 30 to 45 minutes for breathlessness only. Okay, it's a case only. Okay, breathlessness case and discuss. uh, that things will require more time and efforts. If you want, you can just put in the comment section. I definitely consider that. That's all in today's session. Good night and bye bye.